Еще раз здравствуйте, уважаемые коллеги. Меня зовут Аширматова Дармин, я представитель компании Эр Оптикс. Мы еще раз с большим удовольствием приветствуем вас всех на нашем сателлитном семинаре, посвященном новому прибору, входящему на российский рынок, кератографу 5 от компании OCULUS Германия. Регламент нашего сегодняшнего мероприятия следующий. Сначала будет доклад представителя компании OCULUS о приборе и о тех новациях, которые в нем есть. Затем 5 минут вопросов. И следующий доклад – это доклад Ольги Игоревны Ребенко, это клиника Офтальмо Нова, город Москва, тоже о клиническом опыте применения. И затем снова вопросы. Где-то между докладами мы вас попросим заполнить форму обратной связи, которую мы всегда собираем на сателлитных семинарах. Мы всегда после предоставляем информацию о продукте, а также ряд клинических статей, которые могут быть интересны профессионалам, поэтому мы вас просим, пожалуйста, заполните форму обратной связи. Спасибо. И сейчас первый доклад. Это представитель компании OCULUS Флориан Винцик с общим обзором о приборе. Спасибо. Yeah, the presenter works.
Okay. So thanks for the invitation to speak here at the MNTK meeting. And in the next few minutes, I want to give you some impressions about our product, the Keratograph 5M, as a comprehensive tear film or dry eye analyzer. In this chart, you can see the whole functions of the device. Basically, from its measurement principle, it's a procedure topographer, which the first option was used for contact lens fitting to measure the topography. But in the last years, we have developed the device for analyzation of the anterior segments or ocular surface concerning dry eye disease. So, in the lower part, you can see the tear film scan, which measures the tear meniscus height. You can make a measurement or examination of the tear film breakup time, which gives you information about the tear film quality. Also, information about the tear film quality gives you the lipid layer analysis and at least the tear film particle assessment is also for the tear film quality. With the R-scan, we implemented at first the objective classification of the bulbar redness. So we have an automatic classification by the software of the whole bulbar redness of the eye. And concerning quality of the tear film, we can look after the reasons why the tear film quality is bad or very, very low. We can look after the meibomian glands and we can make it visible in the lower and upper eyelid. For the topography, we have additional lens fitting model and also the OxyMap software to visualize the oxygen transmissibility over soft contact lenses. And at least we have an imaging tool for the documentation and the ocular surface, for example, to document the staining status at the eye for dry eye patients. But first, before we want to go into detail of the dry eye functions of the Keratograph, I want to give you some information about the dry eye disease itself. So after the official dry eye workshop from 2007, the dry eye disease is a multifactorial disease of the tears and the ocular surface that results often in symptoms of discomfort, visual disturbance, tear instability with a potential damage to the ocular surface. The dry eye disease is accompanied by the increased osmolarity values of the tear film and the inflammation of the ocular surface. Also, the workshop of the dry eye committee defined the reasons or the causes of dry eye. And they reported that of overall dry eye patients, there is the aqueous deficiency part with just 30%, And the evaporative part, which means that the tear film has a very bad quality, is by 60%. And here we have some further schedules or for the reasons. So if we look at the aqueous deficiency part, there can be two main reasons to have this type of dry eye. If you have a Sjögren syndrome, which is an autoimmune disease, or a non-Sjögren dry eye, if you have problems with lacriminal deficiency or lacriminal gland duct obstructions. The more major cause or major part of the reasons for dry eye is the evaporative part. And here, one major reason is the meibomian glands dysfunction, which means the meibomian or the lipids are produced in the meibomian glands and they don't work very properly, so you have not enough lipids for the tear film, which avoids the tear film from its evaporation.
Not there.
Next. Okay. Okay. Sorry. So in the next slides, I want to show you how tear film or bad tear film can also affect refraction and can affect cataract surgery and can be a side effect of refractive surgery. So if you are in the preoperative diagnostic for cataract surgery, we recommend a full tear film and anterior segment checkup is necessary to avoid unpredictable surprises concerning IOL power calculation. So how can the dry eye affect vision? So here we have a case report of a patient who has a very unstable refraction. So if he comes to the baseline refraction, he has a value of the sphere of minus 6.75 and of the cylinder of minus 3.0. So just 1 week later, his refraction changed to minus 7.5, and cylinder changed to minus 3.75, and the axis was 166. 3 days later, the refraction changed in the sphere to minus 5.25, and the cylinder decreased to 1 minus 0.5, and the axis changed also again of 13 degrees. And then the optometrist find a therapy to manage the dry eye symptoms, and the tear film became stable. And his final refraction, for example, for the left eye was minus 37, and with a cylinder of minus 1.75 with the axis of 84 degrees. What we want to show with this example is that not also in cataract surgery the tear film assessment is very useful. Also for simple refraction for eyeglasses, we have to check if the tear film works properly or not. Otherwise, the refraction data can change from refraction to refraction. Here we have two statements from two very high volume cataract surgeons from Miami, and Dr. William Shetler has also a pentacam and also a keratograph, and he says he looks after every patient concerning if he has dry eye issues, and if he begin with a therapy, he said it doesn't take long to see an improvement. So typically he can see a nice improvement of the ocular surface just after a week or two, and he also recommends very strongly it is important to get significant dry eye under control before the doctor or the clinician proceed with the surgery, because it can potentially affect your IOL calculation. Another doctor, Dr. Busnego, says that dry eye symptoms can be particular a problem for patients with a premium intraocular lenses, because the patient are paying additional amount for the premium cataract surgery, and therefore they're expecting a smoother visual recovery and a better visual result. So, and when patients do not achieve these their expected outcomes with the lenses, surgeons often blame it on the brands of the lens. And his feeling is that one of the most unrecognized causes of the patient dissatisfaction following premium IOL is that the dry eye syndrome is not treated before. Here we have some study from a preoperative and postoperative use of cyclosporine A, which significantly improved visual outcomes in patients implanted with a multifocal IOL. It's called the rhizome of AMO. And the study determined or examined 40 eyes of 20 patients, which got bilaterally implanted with a rhizome IOL. And they begin 2 months before the cataract surgery to give on one eye the cyclosporine A, and on the other eye they got just artificial tears. They their eye received the cyclosporine A and also the artificial tears also 1 month after the surgery. And they found out that the patients or the eyes on which the cyclosporine A was given, that the visual acuity and also the contrast sensitivity under mesopic and photopic light conditions improved significantly. And the conclusion of the study was that a difference in quality of vision may be the difference between happy patient and unhappy patient. And for this, they recommend that type of prosthesis should be used in patients over 60 who are receiving a multifocal IOL. The role of dry eye in the refractive surgery. So after a study of Shoya and Toda, 20% of patients who are undergoing LASIK for myopia develop dry eye with a compromised tear function at least 6 months after surgery. For the femtosecond laser, it is reported that dry eye symptoms after myopic LASIK with a femtosecond laser was mild and improved after 3 months. And with the SMILE procedure, less pronounced impact on the ocular surface and corneal innervation compared with LASIK, further reducing the incidence of dry eye disease and subsequent degradation in quality of life after refractive surgery. So all patients which has undergone a refractive surgery will come back to the clinician or to the doctor and in some time and are potentially cataract patients. And then you have also to manage the dry eye diseases or tear film problems when you make your IOL calculations before the cataract surgery. What we recommend is for cataract and refractive surgery for sure the Pentacam XL or the Pentacam HR for the precise corneal measurement, and now with the XL model for precise actual length results. But a combination is just a system of 2 devices. We also recommend strongly the Keratograph 5M for the comprehensive tear film measurements, for further measurements or examinations like the objective bulbar redness results, meibomian glands evaluation, and for the imaging function. This we think is the ultimate analysis for cataract and refractive surgeon for the preoperative assessment of the anterior segment and the ocular surface. The latest software development for the Keratograph 5M is the Genvis Dry Eye Report. It's a standardized dry eye protocol. And for that, you have You have the possibility to have this dry eye protocol before and after your cataract or refractive surgery. So we ordered the tear film measurements after from non-invasive to invasive measurement or examination. And the first examination which we recommend after the dry eye report is the tear meniscus height measurement with which gives you an information of how many tear film is produced from the lacriminal glands, and it's very easy. So you just take a picture of the sharp picture of the lower tear meniscus or of the lower lid. And then you have your ruler function to measure the tear meniscus at central under the pupil and also in the periphery. And if you have a value of less than 0.2, then you know the tear production is not enough for the patient. A very nice function, if you have done the measurement, automatically your measured value will transfer to your dry eye report protocol. The second examination of the dry eye report is to look after the tear film quality. So you make a measurement of the tear film scan, just centrate the keratograph to the patient's eye, and if the patient is aligned to the device, then the software automatically counts the time how long the patient can his or her eye open. And in this display, you see the results, and you can replay the video of the examination again to discuss with the patient where his tear film is unstable. And with the tear map, you can see after how many seconds the respective segments of the ocular surface of the tear film is broken up. So the more you come into the red part, the earlier the tear film has broken up. And if you have a green pattern, you know, okay, over this area the tear film is very stable. It's also a classification behind that. So we have with the label 0, we know, okay, the tear film is quite stable. And if we have levels 1, we have a suspicious tear film with a not so good quality. And if you got the level 2, we know the tear film has a very, very short breakup, very, very short first breakup, and very short average breakup time. Another good feature is to compare directly the tear film breakup time over several examinations. So, for example, this was your baseline examination, and after the baseline examination, the clinician gives dry eye therapy, for example, with a Restasis or with some terminal pulse implementation. And then you can see and compare how the tear film of the respective patient has increased over or stabilized over the different time points. And another point is, with that tool also you can educate your patient, because one very important factor is to enhance the compliance of the dry eye patient is to educate him. So to talk to him what's wrong with the eye and what can he do in the all-day life to enhance the tear film function. The next part, or the next examination which you can do with the keratograph, is the automatically analyzation of the bulbar redness. And you can also directly go into the measurement tool, and you just have to make a sharp image of the vessels of the sclera and of the conjunctiva. And then the software automatically grades or calculates the ratio between the vessels, the red vessels, and the white background of the sclera, and you get automatically the value of the total bulbar redness of the eye. It's very easy, it's very fast, and you got a very good result. So most of the patients do not know what does it mean if you have a redness, a bulbar redness of, for example, 3.8 or 3.9, and for that you can also use this classification tool to show what's the normal range of the bulbar redness of the eye and where does the patient is lying with his value of the redness. So if you have a very hard case of a bulbar redness, you know, okay, it's in the range of 3 to 4, but quite normal is a grade 2, and just a case for 0 is just young kids or children reach this value. A quite new thing, which is implemented in the dry eye protocol, is the dry eye report questionnaire, is the OCI questionnaire. And here we first have, into the calculation of the dry eye profile, we have implemented the subjective feelings of the dry eye patients during their all-day life if they suffer under dry eye. So here your technician or can easily ask the dry eye patient after his feelings if he reads or if he works with an ATM, or how does he feel under windy conditions. So here the patient can give us a short report under his subjective feelings during his dry eye all day life. And also the value of the dry eye questionnaire of the OCI is also transferred to the dry eye report, and you got here the classification from mild, severe, or non-affected. The next thing is to look after the reason why maybe a patient has a bad quality of a tear film, and you can also do the meibography imaging. So for that we use infrared diodes, and but you have to invert the eyelid. So you have to invert the lower lid and also the upper lid to look after the meibomian glands. And after you have looked after the meibomian glands and classified it by yourself, then you got the profile of the tear film conditions of the respective patient. And that's also very good to give something like this to your patient, because then they understand what's their problem and then they maybe enhance their compliance to that. Yeah, concerning meibography, what are the current assessment criteria? Now, if you look after the meibomian glands, you should count or assess the amount of the meibomian glands, how many meibomian glands are in the upper and lower lid. Look after the length of the meibomian glands. Look after the distortion, tilt, or dilating of the meibomian glands. Swelling condition is one part, and for sure the dropout area and atrophy of the meibomian glands in the lower and upper eyelid. That is will come in one of the next software versions. As I showed you from the retina scan, we now have implemented a grading scale for the meibography. So we have also, here we have just 4 grades. So from grade 0 to grade 3. And grade 0 again is very healthy. And if you go more into the right side, you come to more into the severe part with a very great area of dropout. And then you can easily by sliding this picture of the respective patient to the respective position over the classification scale or grading scale. If you click on the Add button, it's also possible to do or to get results or figures from additional examinations, like here from the, for example, for the lipid layer. So for the lipid layer, we look after this physical or optical phenomenon of the interference pattern of the lipid layer. And if you can see here, if the light comes to the first boundary of the lipid layer, some amount of light is refracted and some light is reflected. And because of that phenomenon, we can see here these interference pattern. And what you have to assess is the more colors you can see, which I show you in the next slide, the more oily is the lipid layer of the tear film. Yeah, and here we have some video of a very healthy or very oily tear film lipid layer. You can see all the colors of the spectrum, from blue to purple to brown to a little bit yellow. So this is a very healthy lipid layer, very oily tear film. So here we should look after what we can also see here, or what can be a problem if you think about contact lens fitting. Maybe this patient has some deposits on the contact lens surface. So you have here to recommend some additional cleaning systems. So here the lipid layer is not so big, but it's also in a normal range, we would say. So you have here that these little brown interference colors, and it's also very good distributed over the whole entire surface. So that could be also a very quite good tear film, but not so probably like the first one. The benefits from the lipid layer assessment, with the Keratograph, you can observe the field over the whole placido disc, which is approximately 8 to 9 millimeter. With the slit lamp, you have just an observable field of 0.5 millimeter, so it's a very, very small amount of field which you can observe. And with the telescope, you are in the middle with an observable field of 4 millimeter. Yeah, with a dry eye report, your individual dry eye protocol, it's also possible to print out all your figures and results for the patient. Again, here we have the camera image from the retina scan. Below of that, we have the tear film profile. Below of that, we have the single figures which lead us to get the hexagram or the profile of the tear film. And below that, it's also possible to type in your recommendation for the respective therapy plan. So maybe it can be some medications or some therapy with heating goggles for the eyes, or massage for the lower and upper eyelids. And at the bottom of that, we have explained every test which would be performed with a patient in easy words. So that means that these tests or the explanations can be also understood from a person who's not a clinician, who is a let's say, just normal person. Also, it's possible to implement here the logo, or from your clinic or from your practice, so that it's very individual dry eye report. Also, in the time of smartphones or tablets, it's also possible to send this report as a PDF file on the electronic way. Now I want to show you two case reports concerning dry eye. So here we have from an optometrist in Germany. So a dry eye patient came to his office, and 33-year-old hyperopic patient with +4 and +3.75, and it was a long-term soft contact lens wearer, severe dry eye symptoms related from NGD, and the optometrist made a control of the bulbar redness over a period of 84 days by a weekly measurement, and the application of the therapy was the heating eye goggles of the team 2 times per day. That's the meibomian glands from the baseline examination. So you have a very great area of dropout. And also for the lower lid, it's not much. Just here, 1 or 1.5 meibomian glands are visible. And also the baseline examinations for the retina scan was with a approximately just 2, so 1.8, with a quite red eye, and the patient claims about that he cannot wear his her contact lenses very long concerning the dry eye conditions. Also, the left eye was 1.8, and after 44 days of the application of Playfast-Team, so the symptoms were just quite a little bit better. So for the right eye we had 1.7, and for the left eye we had 1.6 for the bulbar redness. And after 84 days, we had a reduction or decreasing of the bulbar redness to 1.2 for the right eye and 1.4 for the left eye. And after that, the patient was quite happy, so she could no longer wear soft contact lenses up to 7 hours a day. And here, the optometrist has just documented the decreasing of the bulbar redness for the right eye and for the left eye over the whole period of application of the Playfast-Team eye goggles. The last application or case report, or should we go further with that you can go? Okay, that's okay. Okay, one last case report of a dry eye clinic in Germany. So you see here very high inflammation rate of the eye with a total redness of 3.0, and of the patient got also the cyclosporine A, and in combination with the heating and massaging eye goggles from the Tier Science company device, and we could see at the third exam date that the total redness decreases to 1.3, and also the symptoms of the dry eye are very decreasing. And in the total, or in the forced exams in May 2013, we had just a total redness of 0.8, and the patient didn't have any symptoms of dry eye. In combination to that, it's the same patient. We see here at the baseline examination, we cannot see any meibomian glands, also in the lower lid and also in the upper lid. At the first examination, after the baseline examination, we can see here a mild meibomian glands structure in the lower lid and also in the upper lid. And after the third examinations, that the meibomian glands in the lower lid are quite good to see. And in the fourth examination, that's the status after the last examination that there are some meibomian glands, but concerning to the swelling condition at the first examination, they weren't able to see because of the inflammation and the swelling condition. Okay, short as a summary, applications or for the cataract surgeons, preoperative evaluation of the tear film conditions, imperative necessary, otherwise high expectations of the premium IOLs cannot be fulfilled. Further helpful assessment criteria for the selection of IOL power calculation. Cataract surgeons can also evaluate if a premium IOL aspheric, toric, or multifocal may be suitable to the respective patients when they analyzation of the pupil size. Refractive surgeons assessment tear film conditions before and after the refractive surgery. Size of the pupil size and for the darkness for choosing the right size for the ablation area. Because if the pupil size is too big, clear reflections and halos may appear in the darkness. Also, we have applications for optometrists or opticians. Comprehensive examinations of the tear film can be performed. Detection of abnormal cornea surfaces like keratoconus, thicknesses like pterygium can be assessed. And also evaluation of the progress of the cornea after contact lens fitting can be done. It's a very good tool for easy documentation of findings of the ocular surface and a great tool, as I mentioned, for the patient education to enhance the compliance of the patients. Then I thank you for your attention, and if you have questions, you can now.
Уважаемые коллеги, есть какие-то вопросы? Если вопросов нету... Здравствуйте, уважаемые коллеги. Есть какой-то вопрос, или мы переходим ко второму докладу? Ну, тогда, если мы переходим ко второму докладу... есть, да?